exploring bipolar disorders, from diagnosis to treatment and neurobiology. I'm Karen.
And I'm Annie.
Introduction. Bipolar disorders, or BDs, are severe chronic mental disorders characterized by periods of manic and hypomanic and episodes of depression that affect more than 1% of the global population. BDs have a strong genetic influence, but their development is best explained by interactions between genes and environmental factors. We will discuss classification, onset, diagnosis, symptoms, as well as the brain's role in its development and the medical treatments used to manage it. Bipolar disorder is defined by the American Psychiatric Association as a mental health condition characterized by periodic, intense emotional states affecting a person's mood, energy, and ability to function. PTs are leading causes of disability in young people, causing cognitive and functional impairment with increased risk of suicide and cardiovascular disease. PT's onset is unrelated to ethnicity, nationality, or socioeconomic status. Bipolar 1 affects men and women equally, while bipolar 2 is more common in females. For this presentation, we will be focusing in bipolar 1 and bipolar 2, which are classified by the severity of its symptoms. Bipolar 1 is characterized by at least one manic episode, which might be preceded or followed by a hypomanic or major depressive episode. A depressive episode or psychosis is not required for diagnosis. The typical age of onset is 15 to 18 years, while bipolar 2 has at least one past or current hypomanic and one major depressive episode. No manic episodes must be present for diagnosis. The typical age of onset is 19 to 22 years. Let's keep in mind that for diagnosis, symptoms must not result from substance use, medication, or another medical or psychiatric condition. In order to be diagnosed with bipolar 1, a patient must have a manic episode, which might be preceded or followed by hypomanic or major depressive episode. A manic episode is a period of elevated or irritable mood with increased activity of energy, lasting at least 7 days or requiring hospitalization. Three of the following symptoms are needed for diagnosis: grandiosity, less need for sleep, excessive talking, racing thoughts, or fight of ideas, easily distracted, increased activity or agitation, and risky behaviors. Now, to be diagnosed with bipolar 2, a patient needs to have at least one current or past hypomanic episode, a major depressive episode, no manic episodes. Um, a hypomanic episode is a distinct period of elevated or irritable mood with increased activity or energy lasting at least 4 days. It shares the same symptoms as manic, but with lower intensity. For diagnosis, at least three of those symptoms must be present. However, in bipolar 2, a depressive episode must be present. A patient must experience at least 5 symptoms daily for at least 2 weeks. Those symptoms are depressed mood, loss of interest or pleasure, significant weight or appetite changes, loss of sleep, sleeping too much, fatigue or loss of energy, difficulty concentrating or making decisions, death or suicidal thoughts. This criteria is based on the Diagnostic and Statistical Manual of Mental Disorder 5 edition. Now, let's look at the neurobiology of bipolar disorders. While the exact causes are not fully understood, research suggests differences in neurotransmitter function in people with bipolar disorder. One of the most interesting neurotransmitter for depression and manic is dopamine, or DA. DA is a key neurotransmitter in the brain's reward system, targeting pleasure and reinforcement responses to activities like sex or shopping. DA imbalance is linked to mood disorders, including depression and bipolar disorder. DA controls motivation and reward, and its deficiency contributes to loss of pleasure in depression. Studies have shown low levels of homophenolic acid or HVA um, at dopamine byproduct in depressed patients, suggesting reduced dopamine activity. Oh, I'm sorry. Um, Now we have serotonin. It's a neurotransmitter that regulates mood, behavior, memory, and digestion, maintaining emotional and psychological balance. Serotonin dysfunction is linked to major depression and, and bipolar disorder. Low 5-HIAA, a serotonin byproduct, is found in some depressed patients, especially those with impulsivity and aggression. Serotonin transporter activity is reduced in bipolar and depressed patients, affecting serotonin reuptake. Serotonergic system sensitivity might serve as a biological marker for bipolar disorder.
Now we're moving on to brain structure and function. Brain imaging studies that have used structural and functional imaging have revealed alterations in brain regions involved in emotional regulation. Specifically, the prefrontal cortex, which is a part of the brain responsible for executive functioning, including emotional response inhibition, has been shown to have reduced gray matter in people with BD. This may contribute to mood episodes. The amygdala is responsible for processing emotions, especially fear and aggression, and this part of the brain exhibits increased activation to emotional stimuli. The hippocampus is involved in learning and memory, and in people with BD shows reduced volume, potentially affecting memory and stress regulation. We'll talk more about stress regulation in a minute. Studies provide evidence that BD is a progressive condition, with repeated episodes having significant impacts on cognitive functioning and brain health. So, as the disorder progresses with additional mood episodes, the brain continues to change through pathological rewiring. I'll get into this a bit more on the next slide, which is on neuroprogression. So, a study that examined the blood cells of people with bipolar disorder compared with people without BD found significant cell damage in those cells of people with BD. Oxidative stress is a kind of molecular imbalance that damages healthy parts of the cell. Researchers found that oxidative stress significantly increased in blood cells during periods of mania or depression, specifically due to mitochondrial dysfunction. The mitochondria acts as an important part of the cell and is the mechanism by which cells deal with oxidative stress. So, this dysfunction in people with bipolar disorder is likely the reason for damage of healthy cells due to oxidative stress. In addition to this, people with BD have been found to have increased cytokines, which are signaling proteins used in the immune and inflammation response. Studies have suggested that constant low-grade inflammation can contribute to mood symptoms. Similarly, people with BD tend to have additional comorbidities and high rates of cardiovascular disease and autoimmune disorders, which are likely linked with inflammation and an overactive immune response. Similarly, dysregulation of the hypothalamic pituitary adrenal axis, or the HPA axis, is common in bipolar disorder. The HPA axis is a crucial neuroendocrine pathway that is responsible for the body's stress response. HPA dysregulation leads to abnormal cortisol levels and stress responses, potentially contributing to mood instability. Lastly, studies have shown that neurotrophic support breakdown may be related to bipolar disorder. Specifically, brain-derived neurotrophic factor, or BDNF, helps to promote neuronal survival, growth, and plasticity. People with BD have significantly lower levels of BDNF than the typical population, especially during depressive episodes. BDNF is important and may provide a clue as to why some of the treatments are effective. So, twin studies that examine heritability suggest that BD has a strong genetic component with heritability established between 60 and 85%. Epigenetic mechanisms play a role in mediating gene-environment interactions and modulating gene expression. So this means that while some people may inherit genetic abnormalities that could make them vulnerable to bipolar disorder, environmental stressors that turn them on may never be triggered and they may never develop bipolar disorder. But while there have not been any single genes found to be responsible for bipolar disorder, multiple genetic loci with small effects likely contribute to this disorder. I've listed some examples here, like the ANK3 and ODZ4 genes, which are involved in neurotransmitter signaling and neuronal function, which we've already discussed. Other genes, like the clock and ARNTL genes, show abnormalities that affect the circadian rhythm. Circadian rhythm disruptions are common in bipolar disorder and may contribute directly to mood disorders, specifically mania. Consider how during manic episodes, individuals might not sleep for a week without having any kind of internal cue to do so. This is clearly related to dysfunctions in the circadian rhythm. And moving on to treatments, I think that psychotherapeutic treatments are often used in combination with pharmacological treatments. So CBT has shown some effectiveness, and the other psychotherapeutic approach that's worth mentioning here is family therapy. This is because family tension has been associated with relapse and manic episodes, so alleviating some of that tension through family therapy has shown to have some benefit. Moving on to pharmacological treatments, lithium salts are the oldest and most well-established treatments. They're likely successful because it impacts multiple neurotransmitter systems and they have neuroprotective properties. Remembering that BD has significant neurodegeneration and neuroprogressive properties as related to BDNF and other neurotrophic factors. Importantly, lithium is also the only pharmacological treatment that reduces the risk of suicide, which is significantly higher within the BD population, with around 20% of those who have been diagnosed with BD eventually dying by suicide. Atypical antipsychotics are also used and have been shown to be effective with acute manic and depressive episodes, as well as maintaining regular mood. These work on the dopamine and serotonin receptors. Treatment with typical antidepressants like selective serotonin reuptake inhibitors is particularly controversial because SSRIs prevent the reuptake of serotonin. This is associated with a switch into mania or hypermania. So these drugs are typically used in combination with alternative mood stabilizers or antipsychotics to address mania. Treatment non-adherence is unfortunately common with bipolar disorder. Given that the nature of euphoria during manic episodes feels so good, is euphoric in nature, it prevents people from wanting to take medication that inhibits these sensations. So in conclusion, bipolar disorder is characterized by its fluctuating nature, with patients experiencing episodes of mania and depression. Research suggests that bipolar disorder is the result of a combination of genetic, environmental, and biological mechanisms that we've discussed today. Bipolar disorder is a chronic and debilitating disorder which requires a specific treatment plan that takes into account the changing nature of its presentation and the difficulties that individuals with bipolar disorder have with medication adherence. I think we've shown that more research into the treatment of bipolar disorder is necessary to improve the lives of many individuals. Here are our references. And thank you for your time.